Morning, ma'am. May I start?
Hi,
With...
Guru.
Hi,
We'll
ma'am.
start at 9:30. More people will join. So they join
Okay.
around these 2-3 minutes.
All right, ma'am. No problem.
Yeah, yeah. So, a very good morning to everyone. I, Dr. Poonam Joshi, welcome you all once again to our ACTRAC Head and Neck academic classes. So, as today's speaker is Dr. Gurukeerthi. Dr. Gurukeerthi is Assistant Professor in Department of Head Neck Surgery at KMC, that is Kasturba Medical College, Manipal, Udupi. Dr. Guru will be speaking on, hello, Dr.
Yes,
Guru
ma'am.
will be speaking on the topic oral potentially malignant disorders. And with this, Dr. Guru, please go
Yes,
ahead with the
yes, ma'am.
presentation. We can see your PPT well.
Okay. So, first of all, salutations to my teacher, Dr. Poonam, madam. I'm immensely grateful to her for inviting me to this lecture series. So, coming to the topic, oral potentially malignant disorders. It's a very primitive but complex topic where most of the head and neck surgical oncologist will come across during their clinical practice. So, as the name suggests, OPMDs refer to a group of lesions and which are having a questionable risk of malignancy, uh, mostly developing in the area of lip and oral cavity and other parts of oral cavity. So before 1978, before the WHO Collaborating Center meeting had happened, so these lesions were categorized as precancerous lesion or precancerous condition. So later, in 2005, in the subsequent meeting, and also 2017, these terms were removed and they they included under one heading, that is oral potentially malignant disorders. As we know, the term pre-cancer was coined way back in 1805, and subsequently various changes have happened, and and the definitions were changed multiple times, and now uh, we categorize these under one heading, that is OPMDs. So as I said, before 1978, these lesions like precancerous lesions included leukoplakia, erythroplakia, palatal lesions in reverse mucous, and precancerous conditions were submucous fibrosis, actinic keratosis, lichen planus, and discoid lupus erythematosus. So in 2017, so all these conditions were included under OPMDs. In addition to all the described conditions, the further various other spectrum of disorders were included, such as PVL, proliferative verrucous leukoplakia, and oral lichen planus, lupus erythematosus, discartosis congenita, epidermolysis bullosa, and actinic cheilitis. So, and also after 2017, various new evidence were emerged to include further the disorders like chronic hyperplastic candidosis, oral lichenoid lesions, exophytic verrucous hyperplasia, and oral lesions of graft versus host disease, because of uh, their tendency to become a malignant lesion in during progression. So brief history, it all starts with the Slaughter's famous hypothesis of field cancerization way back in 1953, which paved way for further research into the carcinogenesis of oral cancers, where we know the multiple hits at the level of molecular levels happens, or mutations happen during the carcinogenesis. During the same time, there are some phenotypic changes will happen, that they are categorized as hyperplasia, dysplasia, carcinoma in situ, and then at the end of the spectrum, they convert into a malignant lesion, that is an invasive carcinoma. So one of the most common type of oral OPMDs we see in our clinical practice is oral leukoplakia, which is defined as per WHO as white plaques of questionable risk, having excluded the other known disorders that carry no increased risk of cancers. So basically, the oral leukoplakia should be a diagnosis of exclusion. So we need to exclude all the uh, reasons for having a white patch in the oral cavity. Then at the end of the line, if you can't diagnose anything related to this origin of these patches, then you can label it as leukoplakia, which is further divided into two types, that is homogeneous and heterogeneous. Homogeneous, as we know, that it is thin and white flat lesions, whereas heterogeneous, which is having some sort of speckled appearance or wrinkled appearance. It can be a small polypoid projections in between, which gives a characteristic of heterogeneous type of leukoplakia. And as we know, the heterogeneous leukoplakia have higher chances of progressing into a malignancy. So these are the few examples of homogeneous leukoplakia as we see in the figure. So this is how it looks like, and these are the pictures of heterogeneous leukoplakia, where we can see a speckled leukoplakia and also nodular type of leukoplakias, which further uh, uh, gives us a hint to say that it has a higher chances of progressing into a malignancy in future. So, as I said, so there are certain red flag signs where we can to suspect to have a risk of malignant transformation, such as lesions which are more than 200 millimeters square, and known homogeneous or heterogeneous leukoplakias, and also whenever the lesions are in the like in on the subsides like tongue and floor of mouth, and also more in females, and when the patient is not having any history of tobacco chewing or any other habits, and also when patient has a family history of positive family history of cancer. So these are all the red flag signs where we can have a high suspicion of having a harboring a malignancy in later in life. So this is the recent overlook into metabolomic profiling of these lesions. What are these? So as we know, the epithelial cells they generate energy using various metabolic pathways such as glycolysis and through using a ketone bodies and also amino acids. So these results in various byproducts, which can be amino acids and other byproducts as well. So they say they looked into uh, the levels of byproducts when OPMDs getting converting into converting into a malignant lesions. So they found out that few of the byproducts like phenylalanine, valine, glutamine amino acids are increased in levels when OPMDs have has a higher chance of malignant transformation. So hence this can be utilized in various oral screening programs where we can pick up the early lesions and start the treatment as earliest. So this is done using a various non-invasive method of sample collection like saliva, serum, or plasma. And especially in oral cancers, the saliva is the medium where we can do all these metabolomic profiling using various methods like NMR, that is nuclear magnetic resonance spectroscopy, mass spectroscopy, gas chromatography, and capillary electrophoresis. Though these are still in a primitive stage of experiment, so in future we expect these things to be incorporated in our daily clinical practice. So, as I said, leukoplakia is nothing but the diagnosis of exclusion for white patches. So, various differential diagnoses when you see a patient with white patches include white sponge nevus, frictional keratosis, morceo baccarum, chemical injury, acute pseudomembranous candidosis, leukoedema, lichen planus, and lichenoid reactions, DLE, and graft versus host hairy leukoplakia, and leukokeratosis nicotina. So these are the few examples where we can find out the cause for each these diagnosis, and we can rule out leukoplakia. So these are again examples of the similar looking alike lesions for leukoplakia, such as frictional keratosis because of the tooth trauma and also candidiasis, nicotinic stomatitis in case of a smoker, chronic smoker, and also uremic stomatitis because of the systemic conditions. So another example of a type of leukoplakia is which is named as proliferative verrucous leukoplakia, which has a distinct features like multifocality and also has a higher risk of progressive clinical course and higher malignant transformation up to 20 to 70%. So these lesions evolve from one or more foci of leukoplakia, which is gradually spread or fused together. So this is first described in head and neck, one of the articles in head and neck where they did a meta-analysis of PVL to look for malignant transformation rate. So they come up with the rates up to 50%. If you diagnose PVL, they have higher chances of malignancy, and almost up to 50% of the cases. So there are few criteria which are given by Serrero Lepedra is one of the seminal paper on PVL, where they included they categorized into two, that is major criteria and minor criteria. Major criteria includes more than two different sites of involvement within the oral cavity and existence of verrucous area and spread or engrossed during which is engrossed during the development of disease and recurrence in a previously treated area, and also the microscopy shows hyperkeratosis to verrucous hyperplasia and verrucous carcinoma in some lesions. Minor criteria includes an oral leukoplakia that occupies at least 3 centimeter when adding all the affected areas, and also it's more commonly seen in females, and patient should be a non-smoker, and a disease evolution should be higher than 5 years. So three major criteria or two major criteria plus two minor criteria will diagnose PVL. So these are the WHO 2017 criteria for pathological reporting of epithelial dysplasia. As we know, there are cellular changes and architectural changes which are looked at in epithelium. So I'm not going into the details as it's shown in the table very well. So there are many staging and classification have been put forward for staging oral leukoplakia. This is the one of the most sorted leukoplakia classification, considering the size of the leukoplakia as well as pathology based on the dysplasia within the lesion. So as described, it is divided into stage 1 to 4. One is as it's shown, considering the size of the leukoplakia and the presence or absence of epithelial dysplasia. It is further divided into stage 2, 3, 4. Various combinations are included. So, and also at the molecular level, when you look at, so some of the expressions of S100, A7, loss of heterozygosity, podoplanin, DNA content, P16 methylation ploidy were considered, and it's seen that these are in higher levels are seen during during the malignant transformation. So when do you want to do a biopsy? So in these lesions, when ulcerative or erosive lesions are persisting for more than 3 weeks, and also when the lesion, as I described before, if it is a larger surface area, you better go ahead with the biopsy. And also heterogeneous leukoplakia is another indication for getting a biopsy done. And the most common subsites like tongue and floor of mouth, which also has a higher rate of malignant transformation. So better we suggest to do a biopsy, and also higher age group, more than 40 years, female gender, no risk habits, and with a family history of positive family history of malignancy and with a speckled appearance. And if the lesion persists for 2 years at least, we should go ahead with a biopsy. So these indications are given by again Indian consensus guidelines for oral OPMDs. So again, a very interesting article where they have concised all the guidelines for diagnosis as well as management of OPMDs as per the requirement of Indian population. So this is again as suggested by Indian consensus guidelines for OPMDs, where they have categorized into essential, optimal, and optional treatment for these lesions. So essential treatment has a higher level of evidence, whereas optimal and optional treatment has a lower level of evidence, and it's still in a equivocal. We can say the results are equivocal. So, as the essential treatment includes the absolute abstinence from tobacco chewing, and also dietary modulation, where the daily consumption of green leafy vegetables are promoted, and also some lesions like chronic keratotic candidiasis, where we can use a topical antifungals like clotrimazole, and also topical vitamin A applications. 25,000 international unit twice daily for 90 days are recommended. And also referral mapping. If patient is still having these lesions for more than 3 weeks or 2 weeks, probably you can refer to the higher center where the cancer is diagnosed and further managed. And also regular surveillance is of utmost importance. Every patient should be followed up every at least three monthly during the first year, and also further follow-up has to be done at the interval of 6 months, at least for 5 years. So optimal treatment again includes the same thing, and there can be some centers use as a prophylaxis following a surgical excision, but still, as I said, the results are unequivocal. So it has to be a optimal. It can be an optimal treatment or optional treatment. So further, the surgical procedures like electrocauterization, laser ablation, cryosurgery is being done in various centers with not much positive results. Again, the management of high-risk leukoplakia, as the name suggests, is a high-risk category, so we have to be a little aggressive in dealing with these kind of lesions where the diagnosis has to be done through biopsy and look for any dysplasias. And if dysplasias are present, you can go ahead with the surgical excision followed by any sort of prophylactic chemo prevention prophylaxis. And other modalities of surgical treatment includes laser ablation or cryosurgery, electrocauterization, and also the new evidence is being generated with the utility of photodynamic therapy for these kind of OPMDs. And also in these lesions, also regular surveillance is of utmost importance. Patient has to be followed up in a regular interval. Erythroplakia, again, it's another spectrum of leukoplakia where the WHO 1978 meeting, they defined erythroplakia as a fiery red patch that cannot be categorized clinically or pathologically as a definable disease. And as it looks, it is a flat and smooth with a granular surface with a higher malignant transformation rate of up to 45% or 40-40%. So again, the diagnosis, since it's a high risk category of leukoplakia, again we can go ahead with the biopsy or a excisional biopsy. And if a patient is having a severe dysplasia or carcinoma in situ in some cases, so again the regular surveillance is recommended in these kind of lesions also. So as we see here, it's a fiery red patch with a granular surface. So surveillance, as I told, every 3 monthly for at least for during first year after surgical excision, and then 6 monthly, and also educate the patient for self-examination. Beyond 5 years, if the patient is not compliant enough for a regular follow-up, he can be taught the 6-step self-exam for oral cavity cancer, as shown in the figure. This is the method where they look into the mirror and look for any kind of suspicious lesions by themselves. As we know, the oral cancer can also save a lot of life. So next category of OPMD is oral submucous fibrosis, which is nothing but a chronic insidious disease that affects the oral mucosa, initially resulting in loss of fibroelasticity of lamina propria, and as the disease progresses, it results in fibrosis of lamina propria with submucosa of the oral cavity along the epithelial atrophy. So prevalence is almost 5%, and it is which is more commonly seen in Southeast Asian countries, where because of the higher usage of betel quid compared to the Western countries. The malignant transformation rate again varies, and it is still higher in case of in Southeast countries compared to the West, and it varies between 5 to 16%. So there are many classifications were proposed by various uh, authors like Kannan and Andrade, Kerr et al. This is a classification given by Kerr et al. Where they have staged the progression of OPMDs into mild, moderate, severe, and again stage 4 is further divided into stage 4A and 4B and 5. So the main presentation of the patient would be the trismus, which gradually worsens as the stage progresses. Suppose another that is early advanced. I'm not going into the details. It's just the stage at the advanced stage, patient will have a definitive trismus, sometimes as bad as less than 1 centimeter mouth opening. So what are the etiologies of oral submucous fibrosis? It can be an immunological cause due to the inflammation and autoimmunity, and chronic irritation because of chewing betel nuts. And this is the one of the most common cause cited for OSMF, especially in the seen in Indian subcontinent as well. It can be due to chewing tobacco, chewing clay, chewing fennel seeds, and drinking and smoking. Of course, can give rise to OSMF. And trace element deficiency is also attributed to this. That is a deficiency of vitamin B, C, and micronutrients like iron and copper. Genetic factor can predispose OSMF, but all these are multifactorial. I would say the multifactorial uh, etiologies for development of OSMF. Coming to the pathogenesis, the one of the most common cause of using arecanet as you see in this picture, which is very commonly used as a betel quid. So which contains alkaloids, polyphenols, and trace elements. Trace elements like copper can also result in increased like fibroblast and myofibroblast, which can result in increased collagen production, collagen production followed by collagen degradation and abnormal cross-linking, which is the cause for causing a severe trismus or loss of fibroelasticity. Pathological stages of OSMF include earliest, early, and middle and late, where we can see in the later stage, all the collagen fibers are glassy with narrowing or occlusion of blood vessels because of the vascular and endothelial injury, and epithelial atrophy is seen, and some epithelia may be hyperplastic and can show hypertrophy as well. So coming to the malignant transformation rate of oral submucous fibrosis is almost up to 6%. It can weigh up to 15% is reported. And multiple biomarkers, again, some of the biomarkers like P10, P63, P53, and c-MYC can be elevated during the malignant transformation of submucous fibrosis. As we know, EGFR is an important marker in saliva. These have shown that OSM uh, 15-fold increase is seen in, whereas in, almost 3-fold upregulation is of grade 3 or stage. If you find any suspicious lesion fibrosis, it's all to do a biopsy for CD34 indicate of harboring a is within. So fibrosis by Indian for OPMDs essentially includes the cessation and physiotherapy, exercises taught to the patient should, and nutritional supplement including the microminerals. Also, the some of the temporal muscle myotomy and injection of hyaluronidase is being tried, but still the results are unequivocal. Optional treatments like Clostridium, collagenase, imatinib, microwave diathermy doesn't to support the routine for in routine clinical. So with the patients with grade surgical of fibrous, sometimes with a temporal muscle myotomy, and sometimes coronoidectomy is also recommended with adequate reconstruction. So again, coming to the next set of like diagnosis, that is oral lichen planus, where it's of a chronic autoimmune condition which can have a, again it can be sometimes a malignant. It can turn into malignant in during progression. The most common type of OLP includes reticular subtype. So the etiology is, as I said, it's because of the autoimmune because of the psychosocial, psychological stress, anxiety, depression, which can contribute to erosive OLP, and also dental materials, some like dental amalgam, can also give rise to this condition. So it's an immune-mediated destruction of the cells by activated T cells, and which results in chronicity in oral lichen planus. The histopathology show feature is superficial band of T cell lymphocytes are seen, and also basal cell liquefaction and basal cell degeneration is noted. So clinical criteria, again, it can be a clinical and histopathological criteria. Presence, the striking feature of OLP is it's always a symmetrical and bilateral. And also it appears like a lace-like network of rice gray white lesion, and also it can be include arrow plague type. So these are the examples for the OLP include in linear, annular, common sites include buccal mucosa. The oral lichen, almost the presentation is almost similar to the lichen planus. Only the etiologies may differ. It is graft versus host disease will have oral lesion similar to the oral lichen planus, and also the material induced OLLS like dental amalgam or drug induced sometimes OLPs can also appear like a lesions. So malignant transformation OLPs. It's again interesting article by Fitzpatrick et al. Where they have found the rate of transfer 3.5% is seen, and also uh, 3.2.5% patients with OLP include topical betamethasone, and it is a used lesion. Some of the drugs like tacrolimus, retinoids, and uh, can be treating these conditions. In the another like diagnosis, that is a palatal lesions in reverse smokers, which is being included in WHO 2007 of OPMDs, we've seen in some part of the like world, in even in so it's like palatal keratosis, excess and ulcerations to be frank malignancy. So as you very feature of the, and again the smoking or abstinence from tobacco related habits, and sometimes the is being given diagnosed erythematosus, immune condition, and oral cavity. The erythematosus striae frequently can be systemic. So oral case of systemic lupus erythematosus, 25 patients presents with, and most commonly oral ulceration. Differential diagnosis include be diagnosed biopsy show epithelial deposition, whereas treatment includes a quin and anti keratosis actinic cheilitis, the disorder that damage and which affects especially the vermilion lip is getting affected. Mutations include uh, erosive in the cause of the long rays and keratosis, dryness, and also erythema ulceration. Treatment excision using various modalities like and also the chemoprevention, topical retinoid, uracil cream, photodynamic recommended for these disorders like disc and dermolysis bullosa. These are the most commonly, and so they develop plaques in the dorsal with leukoplakia, but kids and young age the diagnosis. and have a undergo transformation. So again, the for discouraged where will more than 65 to 80% of patients will leukoplakia. So decay which alters telomere function can these kind of and it's most fourth treatment can adjunct detail oral screening oral cancer uh, topic. These are the few techniques where uh, examinations in having vital staining, Lugol's iodine on autofluorescence, which uses a fluorophore collagen elastin and the wavelength the rays with to detect of the lesions and also luminescence also are very used. So now interest is developed imaging unique these lesions using where optical various visualization of um, vasculature under the epithelium is uh, looked at and various category types of intrapapillary capillary loops have been described. Based on this, which can predict the malignant nature or which can predict the invasive nature of the lesion, and appropriate biopsies can be taken. So again, the other agents include optical coherence tomography and high frequency ultrasounds. So these are all upcoming tools which can aid our clinical practice in future, though which are still it's in an experimental stage, most of them. So, say few words on photodynamic therapy. This is a systematic review and meta-analysis done by Binal et al., where they have found that the photodynamic therapy is effective in dysplasia when the lesion OPMDs with dysplasia is present. So PDT is an effective method. So most of these included these systematic review included most of the RCTs, non-RCTs, and also single arm studies. The forest plot for single arm studies showed almost 60% of complete response with photodynamic therapy for OPMDs, whereas RCTs and non-RCTs, when they compared PDT with the other methods of treatments like including the steroid application, they didn't find any superiority. So, but still, the results are very encouraging. So, probably this is the way forward for these treatment and management of OPMDs. So, take home message. So, oral screening has to be is an important part of our clinical practice as a head and neck oncologist. So, uh, we should look for all these uh, we should uh, we should analyze and we should look and we should diagnose these OPMDs as early as possible and initiate appropriate treatment to prevent any further delay in the treatment. And also we should educate our patients for cessation of habits, and also novel chemopreventive drugs are new modality of treatment or can be uh, a new experimental area where we can explore further and do research into this way of treating this patient. And also optimal use of salivary biomarkers. As I mentioned before, salivary biomarkers can be incorporated in our routine practice, probably if we get a good evidence for this. And thank you for patient listening. Any questions?
So thank you, Guru. Excellent lecture. Actually, it is quite a big topic, and
Yes,
you
ma'am.
summed it up in half an hour, and I'm really thankful for that. I think there are a lot of questions, Guru, in the
Yes.
chat box for you. So I will read it out. So one is like, can erosive lichen planus present with with oropharynx lesions, as local application of steroid is not possible in oropharynx. How do we manage that?
Ma'am, oral lichen planus, again, it's a autoimmune disease. So if you're not amenable for any sort of topical application, systemic steroids is an option for these kind of lesions since it's autoimmune. So that
Yeah.
is one way of dealing with that, I think.
Correct. And most of the time, I personally feel, at least in my experience of like some 15, 20 years, we don't see that often lichen planus in the oropharynx. So once in a while is always going to be there in any branch, but most of these lichen planus lesion you do see in the oral cavity.
Yes, ma'am,
And
I
in
do
fact,
agree.
even with your this the use of steroids, it will be local application and they will go for a while, because like you rightly said, these are autoimmune diseases, they will never go forever, so they will
Yes,
have
ma'am.
plus and minus phases. So another question is, what are the outcomes of band excision plus minus coronoidectomy in grade 3 oral submucous fibrosis?
Ma'am, these are all, as I said, for the advanced stage of Christmas, we do recommend coronoidectomy with the band excision and all. But as I seen in our like routine practice, so they do come back with the trismus again. It's not a permanent solution, as I see in our patients coming back with the same complaints again and again. It's actually a very difficult to treat condition. My personally, I feel that way.
Correct. So I think one more point I would like to add is that whenever there is band excision, so the recommendation would be to do it bilaterally because it's a systemic disease. And if you have to do it, and then coronoidectomy, ideally it should be bilateral. And then you have to reconstruct it with some kind of flap. So, and then more than that, more than the surgical part, the part which is going to be most important is going to be the active oral physiotherapy, mouth opening exercises, because in the
Right.
initial phase the patient will do, and later on they stop doing it. So you have to counsel your patient to do it very actively, at least initially, because they will be painful, they won't do it, and then it has to be continued at least for another 6 months, so that the permanent fibrosis, by the time it sets in, you have at least some sort of acceptable mouth opening. But like Dr. Guru rightly said, these you have to understand that even after doing a bilateral flap or a vascularized flap, many a times even they get fibrosed because of the underlying mechanism of the this hello
Yes, ma'am.
yeah,
Yeah.
because of the underlying mechanism of the this collagen dysregulation. So even they get fibrosed. So sometimes it is really difficult to treat, but still you can go ahead and do like that. So
Right.
another question is oral exercise in grade 3 oral submucous fibrosis. Patient complain, how do we deal with? What should be the ideal time? So similar question, Dr. Guru, oral exercise in grade 3 oral submucous fibrosis. Patient complain of severe pain. How do we deal with it? And what should be the ideal time and frequency of oral exercise?
We have in these kind of, yeah, it's very common. These patients do complain of pain when they advise to do a jaw stretching exercises. But the thing is, we should motivate our patients not to stop because of the pain. Pain will be the pain has to be there if we are if they are doing it correctly. Patient will have pain, but the only way they can they can get some sort of result will be because of the compliance. If they are not compliant enough, they are going to go back to the same situation, the same grade of trismus again.
Correct. So you have to talk to the patient. They have to understand why they have to bear pain for a while, and then the active physiotherapy or the oral exercise is the only way to go ahead. In my practice, I tell the patient that if you are not going to do it now, it is going to be like a fixed structure, like you put a cement, and we'll never be able to open the mouth. So some sort of your counseling and extra attention and following the patient again and again would be helpful. That would be the way to go. So, do oral lichenoid lesions turn into malignancy? What is the percentage of malignant transformation rate?
Yes, ma'am. They do transform into malignant, as I mentioned in my lecture. So it's almost not very common, maybe around 6% till 5 to 6% can turn into a malignant. malignancy.
Right. So,
Yeah.
what is the etiology of non-tobacco induced leukoplakia?
It can be because of the, as I said, because of the constant trauma. Could be because of the teeth or sharp teeth, or most commonly this is seen when patient comes with the especially the non-tobacco patients. They do present with the tongue cancer, so tongue lesions. So it is seen that the sharp tooth, which has caused the constant trauma for a long time, can result in initially the OPMD and probably turning into a malignancy in future, ma'am.
Right. Any use of adjuvant RT cis for recurrent oropharynx, especially soft palate? I think this is beyond the scope of this lecture.
Surgery.
So we will not take it. Sorry for that. We can take in one of the lectures when we do it oropharynx. But just to tell that, okay, for oropharyngeal lesions, the primary treatment is usually a non-surgical treatment. That is usually because of so many reasons. And when you give cisplatin and RT, usually it is for advanced lesion. It can be considered for soft palate. How does the OSMF transform into malignancy?
So OSMF can have, I showed in the advanced OSMF, there is again the role of like the cells will go into hyperplasia and sometimes turn into a dysplasia as a spectrum. Again, the OSMF is due to the alkaloids and polyphenols which are present in the betel quid, so which can cause reactive oxygen species as well as DNA adducts can also be can also be formed by these alkaloids. Again, it's similar to the tobacco. It can result in like molecular changes subsequently into invasive cancer.
So, does dysplasia always precede during the malignant transformation of oral potentially malignant disorders?
Yes, ma'am, because the presence of dysplasia is the one which we have to be very wary of, and we should be very careful in observing or follow up, doing a follow up in these kind of patients. Because presence of dysplasia gives a clue that it can turn into a malignancy in future. So that is the one of the things which we should be wary of.
Right. So, having said that, what I would say is that, see, dysplasia again depends upon the pathological assessment, and there will be some sort of inter-observer differences. There's a lot of literature on that, but some sort of dysplasia usually is there before the malignant transformation. But in fact, even without dysplasia, suppose there is hyperplasia, hypertrophy, even in those cases, there's data to suggest that very less, but around 4 to 5% of them can also undergo malignant transformation.
Malformation.
Yeah. So there are no proven malignancies. Since there are no proven malignancies, how do you follow up these patients and what should be the frequency?
So as I said, even in especially in the high risk OLP or leukoplakia and erythroplakia, you should after surgical excision you should advise at least 3 monthly follow up for the initial year, and also the subsequent years you can follow up to 5 years. You can follow up at least 6 monthly interval, and then probably you can educate the patient for self examination as I mentioned in one of my slides. So self oral examination is the easiest way to educate the patient and pick up these lesions as early as possible. So they will come and show it to you if they find anything suspicious during their examination. So I think that should be the like a protocol we should follow for OPMDs. And it is also mentioned in the Indian consensus guidelines where they have clearly written how these patients has to be diagnosed, treated, and followed up. So you can just refer to that interesting article as well.
Correct. What is the grading of the leukoplakia? Any role consider severe dysplasia, especially? Does it make any difference in the leukoplakia, severe dysplasia? So, is there any grading of leukoplakia and like dysplasia, severe dysplasia? Does it matter?
There is a grading, as I mentioned in one of the slides. Again, there is a OL classifications where they have classified based on the area of involvement and also pathological criteria, which includes the dysplasia, which is again further staged into stage 1 to stage 4, and various combinations of these the size and pathological dysplasia, like dysplasia is included. So based on that, we can categorize these patients and we can further manage by doing a biopsy or a surgical excision.
Correct. So I think there is one case scenario by
Yes,
one of the student that recently I have seen a patient with ulceroproliferative lesion over right retromolar trigone with tooth caries in a child, girl child, and but the patient has is only 5-year-old. And how should I proceed? So patient has the ulceroproliferative lesion over right RMT, and there is no family history of cancer.
Okay. Is it proliferative?
Yes,
He's
yes, that
not
is.
sure. Yeah, I think probably we should go and check for like biopsies. The one of the way we can find out what exactly is the lesion. It's very uncommon in this age group to have a OPMDs. As I think Madam also agree with it. I hardly see patients with the OPMDs with this age group. So probably maybe some genetic disorder we should rule out if
Yes.
at all it is the OPMD, like something like epidermolysis bullosa or dyskeratosis congenita.
I
So
agree.
probably we should go for a biopsy and find out what exactly it is.
Yeah, so I agree. This is very, very uncommon to have growth in a 5-year-old child. Please evaluate. If you think there is a lesion, we need to do a proper biopsy and we need to do appropriate imaging. Even a CT would do. And then you can, again, we can come to the next class and discuss, and because it is very, very uncommon. So, and next time we'll be having a lecture on the adjuncts for the PMDs because that is also important. This I think you can go ahead with a CCT, but just check because it's a 5-year-old child. Look for the safety of that. So it was a great class indeed and a great discussion by the students. And with this, I conclude today's lecture. We'll meet you again. Thank you so much.
Thank you,
Thank
ma'am.
you.
Thank you
Thank
for
you
the
so much, Guru,
opportunity.
for
Yeah,
such an excellent class. Thank you.
thank you.